Now, let's look at the surface anatomy of the knee joint and how it's viewed in an X-ray. Here we have the femur, and below it we have the tibia and fibula, but note that the fibula doesn't take part in the formation of the knee joint. Overlying the knee joint, you have a sesamoid bone called a patella, which is a floating bone held in place by the quadriceps tendon. Notice that the patella is not in front of the joint, but just proximal to it. It provides some protection for the knee, but mainly serves as a lever so the quadriceps can work better. Now let's name all those knee ligaments we said in the last lecture you'd need to know. There are 4 main ligaments of the knee. These ligaments have acronyms which make them easier to remember. Collateral means on the side and cruciate means cross. They are the fibular collateral ligament, or the SCL, and it's also called the LCL, or lateral collateral, and supports the lateral side of the knee. The tibial collateral ligament, or TCL, is also called the MCL, or medial collateral ligament, and supports the medial side of the knee. The posterior cruciate ligament, PCL, prevents the tibia from going backwards on the femur. And the anterior cruciate ligament, or the ACL, prevents the tibia from going forward on the femur. Now we've already covered the patellar ligament, or tendon, which you can see here. On this image, we also see the medial and lateral menisci that serve as shock absorbers. Note that the medial meniscus is attached to the TCL. Let's look at this knee ligament injury, also called an unhappy triad. I have a great example of this from my time training athletes in the US. Back in the day, they used to tell people not to lunge past 90 degrees or lunge over their foot when they were training because there was concern that they were going to go past the angle and that would lead to shearing force in the knee. So strength coaches would train their athletes with heavy weights at this perfect 90-degree angle. The problem was that their muscles became used to that strict range of motion. Then someone like a football player in this image would play a game and run through the line of scrimmage. They would be in a really bent over position, and their knee would be flexed well past the 90 degrees, and they would be tackled at high force. And since they never trained in this position, their muscles weren't strengthened in this manner, and as a result, they would give away. So in this case, the knee would be left to rely solely on the ligaments to support it, and would result in a lot of knee injuries. Eventually, the practice of strength coaching has changed when they realized that they needed to train athletes through a full range of motion with heavy weight, even at very flexed or contracted positions. This was the only way to help strengthen the muscles so they could withstand this sort of trauma. Even with proper training though, you can still get injured when enough of force is applied, and now we'll see how. So what happens with this guy who's being tackled? He gets bent over backwards and his body twists away from his foot, which is fixed to the ground. As a result, he ends up with 3 injuries, an ACL and TCL tear plus damage to the medial meniscus. Quite often, the medial meniscus and the medial collateral ligament get injured together because, yes, they are attached. Not in all cases, but in many. I also work with a hockey goalie who damaged 3 of his 4 main ligaments in his knee. And he was great for labs. We used to use him all the time to demonstrate the different positive tests. The anterior drawer signs is a test you can perform to determine if the ACL has been torn. Moore describes it in this image in terms of movement of the femur, but I find it much easier to remember if it's described in terms of movement of the tibia, as this is how it's tested. So the ACL prevents the tibia from sliding anteriorly on the femur. To test it, you get the individual to lay supine and you would fix their foot, usually by sitting on it or holding it down in some way. Then you'd pull on the back of the patient's leg and try to move it forward. If the leg moves anteriorly, there's damage or laxity to the ACL. To test the PCL is the posterior drawer sign. This is simply opposite to the anterior drawer test. To test the PCL, the foot is fixed and you apply pressure to the front of the leg. If there's posterior movement in the leg, then you can assume that there's damage or laxity of the PCL. When testing ligaments, always remember to test the good side first so that you have a fair comparison for each individual.